slight change in the program. I think we'll ask Professor David Denning to come up if he doesn't mind. Professor Denning is known to many of us and is often seen as a last resort with difficult cases, and he certainly has a collection of difficult cases from different units around the country that he's helped. He's the Professor of Infectious Diseases at Wythenshawe Hospital in Manchester. His CV is extremely impressive. His publication list is extremely long. And I'm very grateful for Professor Denning coming and talking to us about aspergillosis and tuberculosis.
Thank you. It's a privilege to come. I've not spoken at this forum before, so that's great. Edinburgh is a fabulous city to visit. There's a lot to talk about. I could bore you for 2 days on this topic, but I'm going to try and do it in about 20 minutes. I first want to explain to you, and I'm sure you have registered this, if not overtly, covertly, that Aspergillus is a really extraordinary organism in the sense that you get a whole spectrum of different types of infection in patients. So you can get these acute invasive infections in leukemics and bone marrow transplant, lung transplant patients. You can have allergies, so ABPA and something called SAFs, which is severe asthma with fungal sensitization, and sinusitis. And you can also have infection in people who apparently have normal immune systems. Certainly those with keratitis who get an injury in the eye is normal. And chronic pulmonary aspergillosis or aspergilloma is a group of patients who ostensibly have normal immune systems, although we don't think it's completely normal, but it's not bad. But they have got pre-existing lung damage. And there's no other pathogen that does this. You know, there's CMV, Pseudomonas, HIV, none of them produce an opportunistic infection in normal people and an allergy. And that makes it really challenging for diagnostics and also for management. So I'm going to talk mostly about chronic pulmonary aspergillosis and aspergilloma, and then I've got a little bit of stuff about TB at the end. I just want to emphasize some things that you might not know, and some of it is new, and it's new to us as well, even though I've been interested in this topic for a long time. So first of all, these chronic pulmonary, these are non-immunocompromised patients or nearly non-immunocompromised. We get a few rheumatoids, you know, on 10 milligrams of prednisolone a day and patients like that, but they're essentially non-immunocompromised. They have features of cavitation with or without a fungal bore, and 3/4 of the patients with chronic pulmonary aspergillosis don't have a fungal bore. And they just have cavitation, which is progressive, usually associated with symptoms, and they get progressive loss of lung function. And unfortunately, our radiological colleagues don't recognize that, so they often only recognize it when there's a fungal bore. And so you get reports saying chronic fibrosis and scarring and things like that, but no mention of an infection, Aspergillus, which is a challenge. Most of them have symptoms, although not all of them. And the key test is an Aspergillus IgG or precipitants antibody, which was described at the Brompton Hospital in the early 1960s and as is now used worldwide, apart, I've discovered recently, from the whole continent of Africa, where they don't do it at all. Sometimes we have a biopsy shows the answer, and serology is not perfect. There are patients who have negative serologies, not many, but a few. So we think that there are basically 4 diseases within this chronic pulmonary aspergillosis entity. There's a nodule, Aspergillus nodule, which is really new for us, and I'll talk a bit more about that. A single or simple aspergilloma, which you guys in cardiothoracic surgery know well and are familiar with, which is a surgical disease. Chronic, what we've renamed as chronic cavitary pulmonary aspergillosis. There was a term necrotizing used a lot, but that actually is a group of patients who are a bit immunocompromised and have hyphae in tissue, and it's a sort of low, slow burn, semi-invasive type infection. And this is a much more indolent without any hyphae in tissue. It destroys tissue, but they don't have hyphae in the tissue. And then this can progress to chronic fibrosing pulmonary aspergillosis, or the destroyed lung as it's otherwise known. So this is examples. Here's an Aspergillus nodule. Here's a simple aspergilloma in a cavity with a thick pleural rind around it and a typical fungal bore. This is chronic cavitary pulmonary aspergillosis. This is the youngest patient I've had, who came to me at 18 with this disease, having had TB twice already. And then an example of a destroyed lung with a fungal ball and cavity within it. And as a general statement, for you guys, it's a really good idea if you don't have to operate on these ones. These are the tricky ones. ones, right? These are the easy ones. So, but I did want to talk a little bit about these ones at the bottom because there is a need sometimes to do that. If you look around the world after TB, which is a very common infection, as you know, we've done an analysis based on work done in the UK in the 1960s, published in 1970, where they looked at patients who'd had TB in cavities and how many had features of an aspergilloma. And if you do those calculations and you work it out worldwide, you end up with an awful lot of patients, about 1.2 million. And given that we treat most of these patients medically, or sometimes they're not treated at all, that's a lot of antifungal therapy, and in many places in the world they can't afford it. So there's actually a need to probably do more surgery than is currently being done. And one of the ways we're trying to do that is through a foundation we set up in Geneva, where where chronic pulmonary aspergillosis is one of the major features in this topic area. And there's a real need to educate, get the diagnostics out, the treatments out, and including surgical management. So what are the indications for surgery in this context? There is the removal of a nodule, which may be done for diagnostic reasons. Usually these patients come because they've got lung cancer. In fact, for most, well, many do, most do, not all of them will. The removal of a single or simple aspergilloma. The other thing is, the idea there is to aim for a cure of the disease. You just want to get rid of it, and then the patient doesn't have to take antifungals, and they're better, they're cured. Obviously, patients with significant hemoptysis. And then there's this difficult group, which are the patients in whom we can't control the disease medically. And there is a proportion of patients that we cannot get on top of. And we also now are seeing much more azole resistance, and that's a problem too for us. And there is another much smaller group of patients who have really left with this large cavity, which is at risk of infection. And obviously an infection, a big cavity like that, would be a really difficult management problem. And occasionally we've taken these large cavities out when the patient is well. So the simple aspergilloma, very classic example, hemoptysis, positive antibodies, taken out, cured. Straightforward, you're familiar with that. And when you look at the literature, and I've chosen some examples here from France, Korea, India, and Egypt, very, very good results. This is a disease that does well surgically for the right sort of patient, treated in the right sort of unit. What about a nodule? So this is a patient who had this feature, which is reported as being possibly inflammatory, exclude carcinoma, malignancy, and it was thought in this patient to be a carcinoma because of this irregular edge around here. This particular patient had positive Aspergillus antibodies, but the biopsy was done appropriately to exclude carcinoma, and the patient was treated with itraconazole and has done very well. And these are PET positive usually. Some are very avid, some are low grade on the PET scan. And if you look at this one, again, can you be sure that's not a carcinoma? No. These are patients who do need a proper diagnosis. And what we've also found is that while they may have cough and dyspnea, and they may lose weight and hemoptysis, these are obviously not distinctive for the diagnosis of aspergillosis. It's equally likely to be a carcinoma. And not all of them have a positive IgG antibody. So it is important, I think, to diagnose them and make them positive. And we wrote up a series in the thorax just recently with 10 patients who presented with lung cancer. Some of them have been told they got lung cancer in the clinic. And in fact, they have these types of scans and on biopsy various features. And actually, there's a differential diagnosis from the Aspergillus perspective. 9 out of 10 had positive antibodies, and they were all diagnosed histologically. And histologically, you see fibrosis, granulation tissue, and fungal hyphae. So if there's any doubt in your mind about one of these things, then this is the way to go. And we don't actually know what the natural history of this disease is. It hasn't been properly described before in any detail. There are a series with nodules, and they mention Aspergillus as one of the differential diagnoses. And so our approach to this is to do a 3-monthly follow-up for a year, and then we do at least one repeat CT scan. The real difficulty is they've got multiple nodules. Is one of them a carcinoma, one Aspergillus, or what's going to happen? But we do try and avoid giving these patients empirical radiotherapy, because as you know, some of them you can't do a biopsy on. It looks like a carcinoma, and they're sent off for radiotherapy. So I think that decision might need to be reviewed, and possibly serology for Aspergillus might be appropriate before the radiotherapy is given if you can't actually do a biopsy. But the chronic cavitary ones, things like this, are sort of, for you guys, sort of heart sink, oh dear, do I really have to do this procedure? This is a really difficult procedure. And sometimes it's a little bit easier. Sometimes there's this wide neck into the airway like this, and this reconstruction. And they've got positive antibodies in almost all circumstances, which are strongly positive, and when you treat them successfully, they do well. If you look at the underlying diseases for this, in fact, this is our series, across the world, TB is by far the most common, but it's under 20% of our patients. We have an equal number of patients with atypical or non-tuberculous mycobacteria. Some of our patients are lung cancer survivors, so they've already been under the knife, and others have been under the knife for other reasons. This is probably because of COPD, which is a predominant feature here. So we have several patients who've come who've having already had a lobectomy, and then they get aspergillosis as a separate event after the surgery. It's for reasons we don't completely understand. And if you do have chronic cavitary disease, which the Japanese would like to call progressive aspergillosis, this is what happens to many of them, not all of them. This is a lady who had TB, and she had this left upper lobe pleural-based cavitary disease, which she was offered surgery and she declined it. She had a couple more x-rays, she developed an interval fungal bore, and then she fibrosed the whole of her left lung. And as you can see, it's very slow. It occurred over 5 years in this patient. We have had patients in whom this transition has occurred over 1 month or 3 months. So it seems to be very uncertain when you get additional fibrosis and progress to this chronic fibrosing. If you look at the Korean and the Japanese series of these patients, you notice a couple of things. First of all, that this very sharp mortality when they first come in and are diagnosed, and then a gradual loss over the next 5 years of the patients with very high mortalities. And this is the progressive forms. It's not the nodules probably, it's not the simple aspergillomas, it's this cavitary disease. And these mortalities are as bad as many of the tumours that we're trying to treat. So this is a difficult and bad disease for patients. So what we're trying to do with antifungal therapy, we're treating the patients, is the first, in the really ill patients, is try and save them from dying in that first acute phase, usually with intravenous ambisome, sometimes voriconazole or mycofungin. And in the not quite so ill patients, we want to improve their quality of life by minimizing all their symptoms. We want to prevent hemoptysis, and many times we'll do a bronchial artery embolization as part of control of the disease. We want to stop the progression of scarring in the lung so they don't fibrose and lose lung function. Many of them are really on the edge from their lung function perspective, and you lose another 10% and they go from being ambulant to non-ambulant or requiring oxygen. So trying to keep them when they're mobile independent is a big deal. We want to prevent resistance, and we obviously want to avoid antifungal toxicity. We do have some patients who have very few symptoms. Aspergillus is not very inflammatory. It's not like Pseudomonas or pneumococcus. You get much less inflammation. So the patients are much more subtle. And sometimes you just get progression of scarring the lung, and they say, I'm fine, doc, I'm all right. And actually you can see the x-rays getting worse and their lung function getting worse. And we treat those patients as well. So there was a randomized study done in India where they randomized patients to sort of standard care, which meant no antifungals or itraconazole for 6 months. And this is what happened after 6 months. You had 2/3 of the patients were worse, one had spontaneously improved in the standard arm, and in the treatment arm you had about 75% of patients were better, but 23% didn't respond. And then they stopped the treatment and watched them for the next 6 months. And what happened then is that you had a bit more progression. Some of the ones who'd got better deteriorated, and 30% had clearly relapsed. And our perception about chronic cavitary pulmonary aspergillosis is that this is not a curable disease. It's an incurable disease unless you can surgically operate on it. And therefore, most of these patients require long-term, possibly lifelong antifungals. Now, that could change with immunotherapies and new things in the future, but that's our perception at the moment about the more difficult progressive cases. So we're just in the process of trying to write guidelines about how to manage these patients, and this is one of the pages relevant to that. So the simple single aspergilloma, the cure and prevention of life-threatening hemoptysis, lobectomy or pneumonectomy, A rating. No randomized studies, so it doesn't achieve a 1 on the quality of evidence, but lots and lots of data, and this is an incomplete list. VATS, not quite so much data, and it would be nice to get much more data. So there's a series from Chen, there's a couple of other, there's Muniapan here, but it would be nice to know and be able to select which patients you can do VATS and not. And in fact, I think in the Chen series, 14% of the patients needed a lobectomy, having attempted a VATS. And then you've got this chronic cavitary pulmonary aspergillosis, refractory to medical therapy, multi-azole resistance, intolerant to the antifungals. We've got a lot of peripheral neuropathy in some of these patients. Some of them can't take it because they get confused and fall over and so on. Others get life-threatening hemoptysis even despite antifungal therapy. And here, there's still a high A recommendation, but it's a much more tricky operation. And sometimes they need a thoracoplasty or cavanostomy or muscle transposition, as Jibem Masad was talking about. And there's much less data about that for Aspergillus. So we recently published a paper with my surgical colleagues. Shakil Farid was the first author on this, and we tried to write down what the risks were. And I think you intrinsically know all this, but what we've tried to do is put it in a table. So the low-risk ones are an intrapulmonary cavity, solid lesion, smooth-walled, single lesion. The bad ones are those with pleural involvement, cavitary lesion with a fungal board or a fluid level, a very irregular or bumpy surface on the inside of the cavity, which indicates fungal growth, multi-cavity disease, prior radiotherapy to that area, or a prior lobectomy or other thoracic surgery, which just makes the surgical approach more difficult. In terms of a space infection risk, a localized lesion and lobectomy or segmental resection does well, a completely normal chest wall. Those who are having a second operation, scoliosis, ankylosing spondylitis is difficult. Other pleural pulmonary disease, which prevents you getting the lung completely mobilized, immunosuppression, and spillage during surgery, which I'll come back to. And then overall, the poor overall outcome cases, the young patient with good lung function, well-nourished, and no other comorbidities, as you know, does pretty well. But the patients with FEV1 less than, that shouldn't be 10, should be 1, sorry. Older patients, thin patients, reduced albumin, diabetes, other infections, and other comorbidities, who've had a transplant or autoimmune hepatitis or whatever. So these are the factors that weigh in trying to make what is a difficult decision for the patients as well. So one of the things that Juma Masad described in detail was this Aspergillus empyema, and the likelihood, I think, can be assessed using the CT scan to a great extent. Not completely, but if you have a really stuck down area, it's going to be, it's going to be difficult to get out, then this is a high-risk patient. So in our centre, if there is a high likelihood of spillage, we give pre- and post-op antifungal therapy. We use voriconazole if we can, and we will give that for a couple of weeks prior to surgery. If we can't use voriconazole, for example, because they've already had it and they can't take it, or they've got resistance, then we'll use micofungin, and we have used amphotericin as well. There are lots of drug interactions with voriconazole. One of the first patients we did this on about 6 years ago didn't wake up for 24 hours after operation, and that's because the anaesthetists gave her midazolam. And there's an interaction with midazolam, and you get prolonged sedation. So just be wary of the drug interactions, Vori. If you do get spillage, then I think it's appropriate to wash the space, certainly at surgery. Many people have used amphotericin for that. We've experimented with torilidine 2%, which we wrote about in this paper. I don't know if they're any better. Nobody studied it. I don't know if it's studyable, actually. And if they do spill, they need follow-up after surgery. And we take quite a lot of patients from the surgeons and follow them up. And we follow them for really quite a long time sometimes. There's another group of patients, invasive aspergillosis. Don't want to spend a long time on this, but there are patients who need surgery with usually leukemics, although not always. And they may have severe hemoptysis. They have a lesion in immediate proximity to one of the great vessels. And those are the patients who erode into the great vessels and they die of life-threatening, well, it is fatal like hemoptysis within about 20 minutes. I mean, it's awful. And I've looked after some of those patients. You've seen them on the ward. They go home, and on Saturday morning or Friday night, they bleed, and it's all over in 15 minutes, and it's horrible. And you can prevent that if you go in and operate. And there are many people who've done that. There's a big series at the Royal Free that's done that, for example. We sometimes have single lesions that aren't responding to antifungal therapy. So they've had lots of antifungals, and it's really still there. And they need more chemo and so on. And also, it may be better, but not completely better. And they want to have to go and have a transplant. And the lesion that's there is in the way of doing a transplant, which is a decent chance of being curative. So these, in severe disease, in invasive disease, these are the reasons. And there's one series, and I know there are several of these series. This is a series from Zurich, and they looked at their about 15-year events, and you can see that not all the patients survived, about 2/3 survived. Usually it was a lobectomy or a wedge resection. These patients went to surgery with only 75,000 platelets, so not many platelets. They got 4 or 5 units of blood. Some of them got platelets post-operatively. They were neutropenic when they went to surgery. And the post-op complications were not that bad. The ones who didn't survive were worse. And the reason that they died usually was recurrence of their hematological disease. So this is something that needs to be done in a small number of patients, and the CT scan that's reported by the radiologist should indicate which patient should be referred to you. And if you get a call like this about a lesion right on the surface of one of the great vessels, I'm afraid you're going to have to be up all night doing it, or do it in the morning very quickly. It's not something that can wait for weeks. It's a really urgent procedure. Just to make one other point, which is that pulmonary mucormycosis, which is less common than aspergillosis, does better if you can operate on these patients. Now, this is not a prospective randomized series. This is a collected series. So the ones that had operations could have operations, and they were resectable, whereas some of these were patients who, the medical ones only were probably patients who had disseminated disease or bilateral disease. But this is even more difficult to treat than aspergillosis. So if you get asked about this, this is something that's worth doing. And then finally, just a few words about tuberculosis. The indications for surgery are severe hemoptysis, as you know, localized disease not responding to therapy, particularly MDR or XDR TB, post-tuberculous bronchiectasis, which is a particular problem, and in some patients a destroyed lung if they're unwell. And there's a whole series of literatures from all sorts of parts of the world on MDR, XDR TB, and this is one with both MDR and XDR here, and actually they had good outcomes in most of the patients. You can see the unfavorable outcomes, 7%, 15% here, with one death in this MDR TB group. So that's a pretty good outcome. It's not easy to do this, but it is worth it. There's one other piece that's a challenge, and I don't know very much about this myself, which is the endobronchial tuberculosis in this series from Wang, where they had a lot of patients. The patients who had endobronchial TB did really badly. Odds ratio of having a fistula afterwards was 18. But if they reinforced the bronchial stump afterwards, it went down. And they learned that after they'd done it. It was only 10 patients here, so they had some bad outcomes, and then they started to reinforce their bronchial stump. But you can see the tuberculomas and the cavity patients do pretty well, but those with endobronchial TB didn't do well. With that, I'm going to finish. Just for those of you who don't know, we run an Aspergillus website which has got a large amount of information on it of various different sorts, which you may find useful. It's got lots of images for talks and so on, a large number of papers, about 7,000 papers. And in the medical information bit, a drug interaction database, so you can look up all the drug interactions. And with that, I'm going to stop. Thank you very much.
Can I just ask, so if you've got a patient with either a simple or more complex situation, you're planning to operate, but you're concerned about spillage at the time of operation, how long ideally would you treat for before surgery with antifungal medication, and how long afterwards if there is spillage?
Yep. You want to make sure that the tissue levels are adequate before surgery, so you can do that with a couple of days of microfungin. or caspofungin. But with voriconazole, you have to check the levels because there's a lot of variability. So we would start about 2 weeks before with vori and make sure we've got a good level before they go into surgery. Voriconazole is critical to measure blood levels, and it's pretty important with itraconazole as well. Post-surgery, I think it depends a little bit how it goes at surgery. Sometimes, you know, it's easier than you think it's going to be, and sometimes it's not. But typically, if there was only a little bit of spillage and it was not too bad, we'd probably stop at about a month or 2 months. But if, in fact, it's a real problem case and you're in theatre for 10 hours and you thought it would be 3, then we probably would keep going for a lot longer if there's a lot of stuff. And we may decide to treat the patient for 6 months or a year.
Questions from the floor? Richard? While Richard gets to the microphone, my simple question is, should we be treating this like a lung cancer? You're talking about resectability. In that regard, we're talking about staging these patients appropriately and possibly managing them in a specialist MDT?
Yes. Yes, that's true. So the way that we approach this is that they're usually discussed in our big sort of thoracic radiology pathology MDT to begin with, and then we have a specialized MDT just with our surgeons to talk about them. And then they get listed, or they often have a scan and see one of the surgeons, maybe have 2 discussions with the surgeon and so on. And then when they come in, we handle the antifungal therapy as they come in. And our biggest problem is knowing when they're going to come, because when you have them listed, you don't know when they're going to come. And so we tell the patient, you must phone our nurses and tell them when you're coming so that we handle them appropriately. And so that coordination around the surgeries is actually the most difficult part. The discussions before are straightforward, but that part's hard. And then we take them back after the surgical bit is finished and then carry on managing them after that.
So my simple question really, is there ever a role for percutaneous intracavitary treatment?
Yeah, that's an intriguing and difficult question. There's a recent series just published from South Carolina in a series of mostly sarcoidosis patients where they do use amphotericin into the cavity. And the aspergilloma often goes away. In fact, 10% of aspergillomas are coughed up and go away anyway. But the cavity's still there, and the infection is probably still there, most of them. I think it's a temporizing measure, essentially. I think you can sometimes get patients better with that. The French series by Giron, the problem with that was that they made the amphotericin up with suppositories, and it was a non-sterile preparation and so on, but they did have some apparently quite good results. If you have a cavity which is full of the fungal wall and there's no space, you can't get anything into it. It's a problem. Some of the patients have got really tenuous lung function, so if it spills out of that cavity into their airway, you can often have a very sick patient who then needs ventilation afterwards. It's also not clear if one injection's enough or you have to put the catheter in and then do it many, many times. And we have done that a few times, but it's a real performance, particularly with the new rules around aseptic preparation of medicines and not being able to do things on the ward and the pharmacy rules and all the other things that have come to play, which impede some of the work in this area. So I suppose we've done this about 5 or 6 times in the last 6 or 7 years because we've been really stuck. So I think it's a sort of the last resort for certain patients rather than being a first effort.
Any more questions?
There's one more.
Thanks for a very interesting talk. In your own unit's experience, how frequently do you utilize the surgical procedures that Professor Massard was referring to, thoracoplasty, muscle flap transposition? Do you do that quite often?
No, generally. So we get referred about 300 patients with some form of aspergillosis, of which about 80 are chronic cavitary or nodule or something each year. Of those, we talk to our surgeons about 10 to 15 a year, and there's probably 4 or 5 that get an operation. And of those, 2 or 3 are in the sort of difficult category with the cavanostomy or whatever. We've done only 1 or 2 patients with muscle flaps. Mark Jones is here, and he knows some of the other patients we've tried to treat with mini thoracoplasties as well, and they are a real challenge for us. I think part of the reason that we don't operate a lot of the time is that most of the patients have really poor respiratory function. Actually, that's the biggest reason for not operating, is that they come when they're 70 years old and their FEV1s are low, and that's a big problem for us. So we haven't done, and we don't have a lot of experience of these very difficult procedures, because we don't have the young XTB patient who, you know, is a 30-year-old with terrible symptoms and so on. We tend to have these 65, 70-year-old type patients.
Thank you.
Any more questions? Thank you, Professor Denning.